So here we go. Welcome everybody to our Revel session on menopause and HRTs. We have Dr. Lisa Savage joining us. Thank you, Dr. Lisa, for being here today.
I'm happy to be here. Thank you for having me.
Well, we are always happy when we get to talk to doctors in the field. You're board certified OBGYN. You're the director of telehealth at Gennev Telehealth Services. You have a special interest in midlife health and menopause madness. And for those of you who don't know us, my name is Colleen Rosenblum. My co-host Bridget is next to me. Bridget Garrett. We are the co-hosts of the podcast Hot Flashes and Cool Topics. And yes, you can tell by the name who listens to our podcast. We have a demographic of 40 plus. And we talk about everything to do with midlife. So this week we're talking fashion. Last week we talked menopause. Next week we might talk about who knows what. But we're here today on the Revel platform to talk about menopause and HRTs. So if you have questions, please feel free to place them in the comments. We will get to them as we go. They may not be right away, but we will get to them. And I'm going to start off the questions, actually, Dr. Savage, with, can you just explain the basics of HRT? Because I think as soon as women hear it, they immediately think, oh, this is bad. I've heard all these reports. HRTs is not something I want to get into.
Good. So let's start out with the basics. What HRT means is hormone replacement therapy. And by that, we mean replacing the ovarian hormones. There are several, but the two primary hormones that we replace are estrogen and progesterone. The estrogen, or I call it E sometimes, E plus P, the estrogen is a symptom reliever. It's the part of the HRT that relieves hot flashes, etc. The progesterone, which some women don't need, if you don't have a uterus, you don't need the P. The progesterone has one job and one job only, and that is to protect the uterine lining from getting overgrown. If you're on estrogen by itself and you have a uterus, that lining is going to build up and get overgrown and even precancerous. So when we say HRT, that is what we're talking about, estrogen and progesterone, or just estrogen alone if a woman has had a hysterectomy.
What are your thoughts? Because, a lot of women who have either breast cancer in their family or at risk for breast cancer have heard negative things about HRT. So Lisa wants to know, what are your thoughts about HRT for women at high risk for breast cancer?
That's a very good question. And breast cancer is always at the forefront of patients' minds. And it depends on what you mean by high risk. The average risk woman does not have a family history, any personal history of precancerous lesions, etc. But the overall risk of a woman at average risk developing breast cancer on HRT is very, very tiny. It's not zero, but I want to give you some numbers. It's about 8 extra cases per 10,000 women. It's tiny, it's vanishingly small. And so this sort of association with HRT and breast cancer is really misplaced. Now, we do individualize. So if I have a patient who has a really high risk profile, multiple family members, perhaps positive genetic testing, precancerous lesion in the past, well, perhaps she's not the best candidate for HRT. The good news is we have alternatives to HRT. It's not the only thing we can use for symptom relief. But in terms of high risk for breast cancer, we really individualize. I ask patients to tell me about their family history. So there's a lot that goes into that, and it's not a one-size-fits-all formulation by any means.
And when you were talking about that as well, someone asked if they could start on HRT 4 or 5 years after finishing their period.
Yes, that's an extremely important point. So we have what we call a window of opportunity for HRT to benefit us the most and be the lowest risk. The window is from that last menstrual period for several years, maybe up to 10 years. It's a critical window because if we start HRT in that time frame within the first few years after the last period, the benefits are going to far outweigh potential risk for most women. But once the window has closed, after 10 years post last menstrual period, The benefits are not going to be there in the same ratio as the risk. And we talk about risk benefit ratio in everything. HRT is not the only thing we judge with a risk benefit ratio, but it's really critically important that if we're going to use it, if we want to extract maximal benefit while minimizing the risk, that we go ahead and start it in that time frame and not wait. Once you're 10 or more years past your last menstrual period, it's not advisable to start on it. The risks are going to be clicking up because of age, among other things, and because body changes have already happened in that time frame that HRT is not going to be able to prevent, and they might be a liability. So window of opportunity, extremely important.
Another person wanted to know about new research in the field of HRTs. Is there some new research that you can make us aware of?
There's one main thing I wanted to mention in terms of new, and it's really good news. There are some medications that are either in or through phase 3 clinical trials, which means they're just about set to come to market. They're not there yet, but these are a new class of medications that act non-hormonally at the level of the hypothalamus. That's the part of the brain that is involved in temperature regulation. So this is going to be a class of non-hormonal drugs that can very well 70% treat hot flashes. And for a lot of women who cannot take hormonal therapy or do not care to take it, but suffer a lot with these temperature instability symptoms, this class of drugs is going to be a game changer for that subset of women. So we're really excited to see this eventually come out. I don't know when that will be, but we're near to having a brand new class of medications for hot flashes.
That's very exciting. Yes.
It is exciting.
Yeah.
Breast cancer survivors, for example, it's insult to injury if you've had to be treated for breast cancer and then you have debilitating menopause symptoms and you're told that there's very little to be done about them. I suspect that class of patients will be the primary candidates, the most grateful candidates for this new class of medicine.
Someone asked a question, and I think it's a good one, that when is the right time to start HRTs when you're in perimenopause? A lot of women don't even know they're in perimenopause, and it can last up to 10 years. When is that sweet spot?
Well, perimenopause implies that we're not done menstruating yet. And in perimenopause, it's a little tricky insofar as the ovaries are still working, or at least they're sputtering. They work and they don't, and they do and they don't. So periods can be irregular, but perimenopause implies that we're still having them to some degree. What we do a lot in perimenopause, because a woman is still menstruating, is we use a low dose birth control pill. It has E plus P, estrogen plus progesterone. It provides hormonal balance, what I call a happy hormonal balance. It provides a monotonous level of hormones instead of having crazy variability. And it provides cycle control so that those periods can be managed shorter, lighter, predictable. If we use menopause products, what we think of as HRT, in perimenopausal women who are still menstruating, we cannot override the ovaries. And so what we end up with is some symptom relief, but the trade-off is a whole lot of irregular bleeding. And it's not a necessary trade-off. So for women who are candidates for a low-dose birth control pill, it is our go-to in perimenopause. And that is, in essence, HRT, but in that subset of women. So then how long can you take that? How long does that last? I say we're not over the hill till we're over the pill. And what that means is age 55. So at 55, we do have a hard stop on the pill, and we swap over to those menopause products that we commonly think of when we say HRT. And a woman can either go straight from one to the other, or if she wants, she can just stop the pill at 55, be off of everything for a little while and see how she is. And if she's fine, she's fine. And if she's miserable or has problematic symptoms, then we can go ahead and start the menopause products. Usually this can be a very seamless transition between perimenopause HRT and menopause HRT. Similar hormones, but different types of products.
Basically, you're saying we're over the hill at 55. Is that right? Because that's what I'm turning this year. So I'm like, great. Over the
I'm not gonna say
hill.
that. No, I didn't. I'm 60. So I don't want to be accused of calling 55 and up over the hill. I don't feel over the hill, but it's a good little chuckle for women who are hesitant to take the pill. Their 40s, late 40s, and they might really wonder, what is she talking about? Because a lot of women get the impression that after 30 or 35, nobody can take the pill. And in fact, if you're a non-smoker, very important, without limiting medical history, it's our go-to. It's marvelous for women who are still menstruating but need a happy hormonal balance instead of crazy variability that is the hallmark of perimenopause.
I was just going to read, because I think it's posted that she's a breast cancer survivor and had a radical mastectomy.
Yeah.
Her oncologist, who's an expert in hormones, put her on a mild dose of HRT with estrogen.
Mm-hmm.
And because she has a genetic immune disorder, it helps her with her joints, but she's very health conscious and she's miserable if she's not taking the hormones. Is that a good example of when HRTs would play a role?
Well, if a medical oncologist advised that I could take hormone replacement therapy and I needed it for symptom relief, I would trust my medical oncologist on that. If somebody with that level of expertise, a cancer doctor, is given the green light, I don't know why I would question that. My main challenge sometimes in my field of gynecology is convincing oncologists that a woman might be a candidate for some type of hormone therapy. Usually that battle is waged over vaginal estrogen because really any and everybody just about can take vaginal estrogen, including breast cancer survivors. And sometimes I have some convincing to do when talking to medical oncologists, that they act like every single molecule of estrogen that comes within 10 feet of a breast cancer patient's body is sinister, and it may not be. But I guess the bottom line on that is if a medical oncologist gives a green light, I would say, you don't suffer. There's no bonus point for suffering.
I would like to know if you could type in just where this, you don't have to give away where you are, but where is this doctor located? Because it's really nice to see an oncologist, just like Dr. Savage said, that will support this. So if you could just type like the area where this doctor is found or what the doctor's name is even, I think that'd be helpful if someone happens to be in that area and has a similar situation.
But keeping in mind too, from what I understand, the patient had a bilateral mastectomy.
Yeah, okay.
If there's no native breast tissue left, there's no breast cancer to be gotten. And so that's a unique situation too.
Okay.
Can we also talk about the mixed messages being sent on HRTs since the early 2000s and what is fact and what is fiction?
Yeah, that's a really good point. So I had this epiphany recently that the difference in physicians who are really comfortable prescribing HRT and those who are not sometimes is when you trained. And I trained in the late 80s and early 90s, and we gave every 50-year-old estrogen and we told her she'd be on it indefinitely. Those words came out of my mouth repeatedly in training. But then in the early 2000s, around 2002, the WHI had a study, and it was called, the Women's Health Initiative. WHI is a study, and it came out in midsummer 2002, and it had splashy headlines, and the splashy headlines actually appeared before the actual article. And there's actually some scandal around how this all came out, and I won't go into that, but suffices to say that the headline said, danger, danger, HRT will give you breast cancer, heart attack, stroke, and early death. It's bad, it's toxic, don't take it. Well, it turns out the study, the actual results didn't exactly say that. And it's taken many years. So many physicians, so many patients stopped using HRT cold turkey, and they never looked back. And so then we had many women who went off of their therapy or didn't start it, who have since suffered not only just symptom problems, but long-term health effects. So that particular study, the WHI, it really changed people's attitudes about HRT. So if you train during that time, if you were doing your residency, really in any specialty, but including gynecology, family medicine, and internal medicine, that was the message that you got. It's dangerous, don't use it. And so it's very unfortunate. And if you pick apart the study, any increased risk of breast cancer in the study population was not actually statistically significant. And so it's been very unfortunate that we have this legacy of sort of a danger connotation around HRT when it's really misplaced. Hopefully nowadays we're reaching more women. We need to reach more doctors in terms of the safety, the real risk profile, who is a candidate, who's not. We need not be so afraid of it anymore at all.
Someone else had a question about how much improvement can you expect in osteoporosis on HRT?
Well, HRT estrogen, and specifically estrogen, is really good for bones. But there's a question about whether it really gives you stronger bones or more dense bones. And bone resilience and strength is what we're talking about. Why do we think about estrogen for bone health? It's one thing, and it's hip fractures, right? We want to reduce the incidence of hip fractures in women. Nobody ever died from a broken wrist, but women who break a hip have a significant mortality in the next year or so. It's something like 20%. It's high. So bone strength matters, and estrogen matters for bones in terms of preventing hip fractures. Now, how much improvement might be expected is completely individualized. And mind you, we judge improvement on a bone density test, on a picture. And you can see if the bone density stabilizes or goes up. What does that mean in terms of your risk of hip fracture? It's not exactly correlated necessarily, but I tell patients, if we're going to see any improvement on their bone density, it's probably going to be stabilization. I don't see a lot of real improvement on the report of bone densities. I do see stabilization. We're not losing at the same rate anymore. So that's good. Any actual improvement is icing on the cake. But what I like to see on the bone studies is stabilization.
It was interesting because we interviewed Claire Gill, who's the president of the National Osteoporosis Foundation in the US, I think last season. And she was saying the same thing that you were saying, which is, I think it's like 25% death rate for a broken hip for women.
It is.
And
Yeah.
it was just so shocking to us because she was saying that your bone mass density, it's like at its highest at 25, and then you're just trying to keep it and not lose it.
That's true. Maximum bone density is usually reached by age 30.
Wow.
And so, if we were smart, we would try to maximize our bone density by age 30 by doing all the right things: weight-bearing exercise, adequate calcium, vitamin D. Because after 30, stable is as good as it gets, and there is bone loss usually thereafter. So that's a message we might want to get out to our younger friends.
So true. There is another question which is interesting. There's a woman who has no family history of cancer, but she's 70 and she would like to go on HRTs. And I know that there's an age issue there.
Yeah, there is. Yeah, if you're post 10 years after your last menstrual period, your risk benefit ratio is not favorable. So I would not start a 70-year-old on HRT. And it depends on what the last period was. If somebody had her last period at age 55, I might start it up to age 65. I might. Most patients by the age of 60 or early 60s have been on it and extracted the maximal benefit. Now, there's not a hard and fast rule about when you have to stop it once you have started it, but I wouldn't start a 70-year-old because it's been too long and we're not going to extract the benefit.
Yeah, we had the question, how long can you stay on it? That was her question. Mm-hmm.
Well, we used to say, we should use the lowest dose for the shortest period of time. And that's not really the case anymore. The dosage is based on symptom relief. We titrate dosage to symptom relief. The duration can be variable. We have some patients whose worst symptoms will be over within a few years. We have other patients who have a lot of cognitive problem and they want to take it until they retire, maybe mid-60s. We have a few patients who start on it at an appropriate time and they want to clutch it until the very last breath. I would say that most of my patients historically have been ready to start weaning off. We're seeing how they do around age 60 or early 60s. But again, individual patient history, evaluating why we're on it once a year is a good idea. And there's no rule for every person.
What about estrogen dominance? Someone asked about, can you talk about estrogen dominance? What do we need to know and how is it managed?
That's a term. These terms, estrogen dominance and progesterone dominance, are not terms that I really am familiar with, medically speaking. But what happens in perimenopause, and I'm assuming this is probably where this is coming from, is that there is an imbalance of the ratio of hormones. The estrogen and progesterone don't have their normal levels and their normal ratios at their normal times. But the thing is that in any one cycle, estrogen might be more dominant because you didn't ovulate that month. But in another cycle, you might have more of a preponderance of progesterone. So it's not a static situation. And so I don't assign those terms. I don't use those terms, and I don't manage according to those terms. I manage according to menstrual history, symptom profile, things like that.
And then let's see. Somebody says, "Oh, hallelujah." Let's see. She said, what if your period stopped prematurely due to chemotherapy treatment? What would the window be of beginning HRT?
Would the window change?
Oh, would the window change? Oh, I didn't see that. Okay, yeah.
In those circumstances, women who become menopausal early, say because of chemo or surgical menopause, I think it's critical to start on HRT stat and then to stay on it at least until the average age of spontaneous menopause, and that's around age 51. And in that case, it's a little bit different than menopause hormone therapy. It's more critical because if a younger woman who stopped menstruating at a younger age is lacking those hormones for all of those years, she's at much higher risk for bone loss, heart disease, et cetera. And so to me, that's a special category, and it demands immediate, appropriate HRT and a duration at least until the early 50s.
And following up with that, a lot of women are concerned about their cardiovascular health in aging generally, but also related to HRT. Does it increase the risk?
If it started in that window of opportunity, it may be protective. But if it started after that, then some of the cardiovascular changes have occurred already. They can't be prevented anymore, and HRT might be more of a liability. So window of opportunity comes back again as a critical concept in how it's going to help us or not help us.
Can you just clarify, how does a woman walk into a doctor's office and say, am I in my window of opportunity? Like, how does she know that?
Well, it depends on the LMP, last menstrual period. When was it?
Okay.
And if she says it was a year ago, 2, 5, 7, then she's in the window of opportunity. It's based on the LMP, last menstrual period.
What about antidepressants? There are a lot of women who go in with perimenopausal symptoms and they're given antidepressants, and sometimes it helps and sometimes it doesn't. But can you talk to that?
That's true. So antidepressants have a place in medicine, obviously, and they're critical in some cases of endogenous depression or even situational depression. But one category, the SSRIs, serotonin, selective serotonin reuptake inhibitors, actually have some symptom relief in terms of hot flashes. In fact, one of them, a couple of them actually, are used as alternatives to HRT in patients who can't take it. But I think that what happens in perimenopause is that mood symptoms may predominate. Anxiety, moodiness, being fragile. And if a doctor hears that, they may be more likely to hand out an antidepressant. So it's not necessarily a bad thing to do. You really have to listen to the patient and find out what are the preponderance of her symptoms. But a lot of women would fare just fine on hormonal balancing instead of an antidepressant. And some women need both. Again, completely individualized.
There was a good question too about hormones and sex drive and any helpful treatments for that.
Oh, yes, we should spend a whole hour on that.
Yeah.
Yes, so sexual interest in women, notice I said interest and not drive. Sexual interest in women is multifaceted. It is not just hormonal, although hormones play an important role. And so there's not a magic bullet for sexual interest in women. We have to address the relationship, the physical, the emotional, and there are many entry points for women into sexual interest. Men are linear. They are desire, arousal, climax, resolution, sleep, right? Linear. Women, we're not linear. We're much more sort of circular, and interest can be piqued in a variety of ways. Now, the first thing to recommend in sexual interest is there any pain? That has to be the first question. Are you having pain? Because in that case, full stop, we have to address that before any interest would come back in. And so often we see patients who present for low interest and they say yes to the pain question. And so it's no wonder then they wouldn't be interested if they're experiencing pain, and we have to address that. There is a marvelous book. I have to just get this book in there. I have no conflict of interest, no commercial interest whatsoever in anything that I recommend, but it's called A Tired Woman's Guide to Passionate Sex. And there are other great books, but Lori Mintz is the author, and she goes into the multifaceted nature of female sexual interest. It's a terrific read for probably women of all ages, but especially midlife. And there's one more thing I really want to say as a takeaway on sexual interest, and that is something called receptive desire. It is different from spontaneous desire. And receptive desire means that desire comes after arousal. Desire comes after arousal. Extremely important in midlife. It's important at all ages, but it becomes a predominant form of desire in midlife. Receptive desire, desire after arousal. Allow for arousal, see where it takes you. Do not make desire a prerequisite for proceeding with sex anyway. That's extremely important.
What about testosterone with that? Because I know, a lot of people are prescribed that, and what do you say about that?
I'm not a fan of testosterone in women, and I could spend a whole hour on that. That presumes that desire in women is strictly hormonal, and that we should be like a man in order to be linear in our desire, etc. Making a woman into a man may have adverse effects. The testosterone that is prescribed for women is not FDA approved. It is not formulated for women. Now, do I wish we had a formulation for women? Yes, we don't. And so these products formulated for men are used in women, and they can have some pretty unsexy side effects. Receding hairline, Adam's apple, acne, clitoromegaly, which is enlargement of the clitoris like a miniature penis. They're not reversible side effects. So the use of it is tricky. It needs to be done with careful oversight. We should hope for a product for women eventually, but it's not the answer to female sexual interest because it's so multifaceted and it ignores all the other parts of female sexuality, which are so, so important. So I think it really does a disservice to women to just say, oh, just take this male hormone and you'll be fine. Who does that benefit? So I would argue that female sexuality is much more complex. It's much more beautiful and rich and multi-layered, and it's not just one thing. So I caution against the use of testosterone in women. Again, it's not that it can't be used, but it has to be used with very careful surveillance.
Someone also had the comment, don't women's bodies make testosterone?
We do make testosterone. As a matter of fact, it's in very small amounts. We make it from the ovaries and the adrenal glands primarily. Interestingly, this is so important to know, testosterone does not decline at menopause. It goes down slowly over life in both men and women, slowly, but there's not a big drop off at menopause, the way there is a big drop off with estrogen and progesterone.
When you're talking about painful intercourse, I just want to follow up with a lot of women suffer from vaginal atrophy and dryness. A lot of women complain of dryness in the vagina area. Would estrogen cream help with that?
Oh, absolutely. Estrogen, vaginal estrogen in every form, whether it's cream, ring, tablet, suppository. We have lots of great vaginal estrogen products. And the new term that we use to replace atrophy is GSM, genitourinary syndrome of menopause. We used to call it VVA, vulvovaginal atrophy, but apparently the powers that be have gotten rid of that term and we now call it GSM. But I want to emphasize the great utility of vaginal estrogen. A woman should not have pain with intercourse. And if pain is from those thin, dry, fragile tissues that are not elastic, not receptive, that can be fixed. And I want to shout that from the mountaintops. Vaginal estrogen is not absorbed systemically to any measurable degree. If you take two women, one of whom uses vaginal estrogen and the other of whom does not, their blood levels of estrogen will be the same. It's really safe. It's safe for almost everyone, and it can be used indefinitely. So I want to be a huge cheerleader for vaginal estrogen.
So you said indefinitely, so that's any age.
Absolutely.
Okay.
Indefinitely. That can be started at any age and continued indefinitely. It's really safe. It's a game changer. It restores the elasticity, the moisture level, the receptivity, all the good stuff. I think it's way underutilized. It can be scandalously expensive, which don't even get me started. I'll get on a soapbox. But I want to emphasize that, there are ways to cut cost on that. And it is a game changer, not only for comfortable intercourse, but also to prevent recurrent urinary tract infections. The bladder is estrogen sensitive, and when the tissues are thin and dry, they're not so protective, and bacteria can get in more easily. And so vaginal estrogen is not just for the vulva and the vagina, it also has a positive impact on the urinary tract tissues.
That's great to know, because a lot of women in our demographic suffer from frequent UTIs. So that's always good to know.
Exactly.
And I just want to mention for women who joined in a little late, we are talking to Dr. Lisa Savage, who is an OBGYN board certified, and she's also the director of telehealth at Gennev. And Gennev is an online telehealth service where your questions about perimenopause and menopause can get answered. And we will actually, in our Mother's Day giveaway, we are giving away an online appointment in there. So yes. So if you guys are interested, you can go to hotflashescooltopics.com, sign up for our emails, because that'll be on Mother's Day. We have a big bundle of products and services for women in our demographic. So I just want to make sure people know, because we are bombarding you with questions and you're being very gracious. And I wanted to give you a minute to take a breath and have a moment.
I love it.
But with that in mind, can you talk about the difference between HRTs and bioidenticals?
I'm so glad you asked that. This is a common question. The word bioidentical, to us in the medical profession, it means biochemically, molecularly, just like what your body used to make. So go back to organic chemistry and think about the molecular structure of things. Hormones have a molecular structure, and to us, bioidentical means just like what your body used to make. But it's commonly used as a marketing term. It's bioidentical, and that makes it sound safer, more desirable, more natural, if you will, which is another marketing term. It is neither here nor there in terms of safety or effectiveness. Now, I want to clarify, we use FDA-approved conventional bioidentical products. Estradiol is one of them. Oral micronized progesterone is one of them. So we like bioidentical products. We use them, but we use FDA-approved conventional products. You want to watch out for bioidentical being used in a marketing way, because it really does not speak to safety or effectiveness. Now, I want to clarify this other term, compounded, because oftentimes those two terms are conflated. And people might use that word bioidentical when what they really mean is compounded. Compounded means not FDA approved. It is mixed up in a pharmacy according to someone's recipe. And I don't like, and we don't like at Gennev, compounded products for HRT in general, because you really don't know what you're getting. The amount of active ingredient might be too high, it might be too low, it might be completely absent. So I want to clarify the difference between bioidentical and compounded. A compounded product might be bioidentical, but they're not the same. And so you have to sort of discern what term you're talking about and what type of medication you're getting.
And let's see. Oh, Colleen, somebody said that you're direct. I don't know if you saw this message. It said, can you tell Colleen that she has me on direct message?
Oh, okay.
Oh,
Thank you.
Yeah,
Thank you.
The group.
Can we also talk about hair loss? Because a lot of women, there was a question here from Karen that talked about vaginal atrophy, which we did talk about. But a lot of women suffer from hair loss too. Can HRTs help with that?
I never promise that HRT is going to help with hair loss. Hair loss comes from age too, and it does come from hormonal shifts. I don't want to overpromise on HRT and hair. Hair is a skin appendage. I always have my patients go see their dermatologist first because we can attribute it to midlife. We can attribute it to age or menopause. But the fact is, there are many types and causes for hair loss. And in my practice, I think that needs a scalp examination, an actual physical examination, because hair loss can be diffuse or all over. It can be patchy. It can be in certain areas and not in other areas. It also requires some lab work, in my judgment. Ferritin, which is an iron storage product, sometimes is low in patients suffering hair loss. Thyroid dysfunction is a huge cause of hair loss. And so we cannot attribute it to menopause or age without ruling out other things. And so my point on hair loss is always, please see a dermatologist, get an exam, get a workup. And if all else is ruled out, then yes, it may be attributable to age, menopause, et cetera. There are products that people use and recommend for women. Rogaine is one of them. I don't necessarily recommend that, but there are products that can be used once the diagnosis is established. But I always try to be careful about not assuming that hair loss is due to midlife or menopause before ruling out other things.
We did an episode with a trichologist, which we had no idea that a trichologist is someone who's an expert on scalp and hair.
Exactly.
And that's what she was saying, is that it's not always related to perimenopause, and it's not always genetic too. There are a multitude of factors. And so I would recommend to the person who had that question, if you go on our list of podcast episodes, you'll find one with a trichologist that would probably answer a lot of your questions for you. Is 70 and her gynecologist recommended Divigel.
Divigel. Yeah.
Divigel.
It's a form of estrogen. It's a product we use.
So she's at 70 and she's also been recommended 200 milligrams of progesterone. And we were just talking about how maybe at that age range, unless her periods are within a 10-year, in the last 10 years stopped, would that really be helpful for her?
I can't give out individualized medical advice, and without knowing a full history and background and possibly an examination, it would be hard for me to say specifically about that.
Does estrogen, and I completely understand that because it is so, and again, guys, when you get this advice and this information, always check with your doctors, because we're giving general information and everybody is an individual with individual health issues. So you never know what could be contraindicated or what you're going through. So always make sure to check with your doctors. Can you address brain health? Because once known as estrogen protective of your brain health?
It can be if it started in the window of opportunity. We do have some evidence that the brain is very elastic and it has some estrogen sensitivity. And so if HRT is started in that window of opportunity, it can be protective. I think a lot of times women are talking about the brain fog, the cognitive problems, the word searching, can't remember that friend's name, scares us to death because we think we have dementia. But brain fog can very well be improved with HRT. I think a lot of the cognitive and the mood symptoms stem from disrupted sleep. And so I like to emphasize sleep correction or optimizing sleep pattern in terms of brain function, because we all know if you've had a horrible night's sleep, you feel foggy the next day. You're not very sharp. You can't think straight. You're distractible. And so brain health can be helped with HRT. There's no doubt about it. To me, the conduit via which that happens, or a lot of it happens, is via sleep optimization. And there's no doubt that HRT can help a woman who's suffering with sleep disruption to sleep a whole lot better.
That was my next question. What about sleep?
What about sleep? Yeah, I'm always hammering on sleep at Gennev. They probably get tired of me going, sleep, sleep, sleep. It's all about sleep. But I really think it is. I think a lot of it is all about sleep. And so, if you're not getting enough, not only does it have you getting short-term symptoms, it has long-term effects. Sleep deprivation can have effect on weight, diabetes, and memory, you name it. And so I think that optimizing sleep is critical. On that note, another book, I'm a bookworm, so I like to throw out book titles for people who want more information. There's a marvelous book called Why We Sleep by Matthew Walker. And he's got a lot of great information in the book, resources about why we sleep, the importance of it. He's got some TED Talks too, if you want a nugget of information. But HRT can absolutely help improve the sleep pattern, and therefore the downstream symptoms, the mood, the cognition, et cetera, can be improved. Oh, body aches, that's the other thing that can come from poor sleep. So I am big on trying to improve sleep.
With HRTs, I know we talked about bioidenticals and compounding, but someone wants to know, is there one kind of just HRT, or do different companies have different types? And if so, what should we look for and what should we avoid?
Well, there are all kinds of products. It's just like ketchup. If you go to the grocery store, there's Heinz, there's Hunt's, there's, your local store brand. And so for estradiol, which is the hormone we use in HRT for estrogen, there are several products. I have an estradiol tablet. I have a vaginal ring. The Divigel was mentioned. We do tend to prioritize a transdermal or across the skin delivery systems like a skin patch, because those forms bypass the liver and therefore have a little bit lower clot risk. But there are several products, just like everything else in life, there are several kinds or brands of a product. And among those, there may be some differences or preferences depending on individual preferences or what seems to be safest medically for the patient.
Someone else had a question. We talked earlier about birth control, but they were talking about the birth control during menopause. Will it help with sleep? And she says, yeah, she wakes up and can't fall back to sleep.
That's a pattern too. Most women who complain in peri-menopause or menopause of sleep disruption, they usually fall asleep just fine, but they're waking up through the night. And that sleep disruption can be not only from night sweats, which are classic in menopause, but also a difference in the architecture of sleep. You've heard of the stages of sleep, the deep sleep, the REM sleep, et cetera. That pattern gets disturbed with hormonal deficiency. So yes, the pill can help with that sleep disruption in perimenopause. It can.
Someone wants to know the difference between the estradiol patch and an estradiol vaginal insert in terms of the blood barrier side effects and precautions, or are they the same thing?
Those are both transdermal. So a skin patch and a vaginal ring for systemic therapy are both transdermal. In other words, you don't take them by mouth and they don't go through your liver, right? And so both of those forms are prioritized over oral, but some women prefer an oral, a pill, and it's fine. One thing, there's some confusion with vaginal rings because there's one called S-string that is just vaginal estrogen, called Fem ring that is systemic delivery of estrogen. They're both great products. They're in the vagina and they last for a while. You don't have to worry about something every day or a couple times a week. So ring formats and patch formats are both transdermal and they're both fine.
And I wanted to let someone ask for the URL. We are going to be posting this episode both on our YouTube channel, and we'll provide the link in our Hot Flashes and Cool Topics group on Revel. So you'll be able to get to see it once. We just have to edit out a few things and then we'll post it. Someone asked, they said they think they got the brown patches on their neck from vaginal estrogen.
Well, I say never, but I would also say it's unlikely. Brown patch is called melasma, very common on the birth control pill. You can get sort of a mask-like pattern on your face or the upper body, the neck and the face. I usually attribute that to birth control pills, which are a little bit stronger, if you will, than menopause products. But really, vaginal estrogen is absorbed to a very tiny degree, if any. So I would hesitate to make that association, but I would believe someone who said it was absolutely temporally related. I wouldn't discount that clinical feedback or that clinical experience, but for most women who use vaginal estrogen, that would not be a concern.
What would you say to women who have gone to see their doctor and they have talked about their symptoms and the doctor kind of says, well, it's just menopause. You just have to, grin and bear it. And, is the answer find another doctor? Because that's what we always say, but.
Yes, come to Gennev, come see us at Gennev. Gennev.com. Yeah. So I did not say this quotation, but somebody else told it to me and I've been repeating it. Menopause is the only endocrine failure where women are told to just suck it up. Diabetes is an endocrine failure. hypothyroidism is an endocrine failure, do we tell those patients to just grin and bear it and get through it? No, we do not. And menopause should be no different. So if a physician is dismissive, or they say they don't believe in it, or the patient shouldn't take it without really getting a lot of history and investigating it, yes, the answer is find another doctor. Another resource is the North American Menopause Society. Find them at menopause.org. And you ought to look for a doctor who's NAMS certified. Back to for just 1 minute. We do have physicians who are licensed in almost every state. We're not quite to 50 yet, but we're getting there. And so we can do telemedicine for women in many states. I sit here in the state of Texas, but I'm licensed in Florida and California and multiple other states. And so take advantage either of one of our physicians or looking for somebody on menopause.org who is NAMS certified and interested in menopause medicine.
I was just going to ask, for women who are starting to taper off of HRTs and they're either past the 10-year point or they're now reaching 60 and starting to taper off, can they expect to see some symptoms return?
Yeah, probably, but it's a matter of, are they an observation or a complaint?
Okay.
I had a patient tell me that this is just an observation, it's not a complaint. But we can all observe an occasional hot flash and not be too bothered by that. So I always ask patients, is this an observation or a complaint? And there's a whole spectrum of everything in between, right? And so, yeah, if you're weaning off, you might have the occasional hot flash, night sweat, etc. But if they're manageable, they're manageable. But if not, I've had patients wean off and they come crawling back and, begging to be put back on it. And that's problematic. So perhaps that woman could go back on it, or ideally go back to the dose at which she started experiencing symptoms and get above that. I have patients go every other day for a month, every third day for a month, and then off. And if somebody says, oh, every other day worked great, but every third day didn't, I say, well, go back to every other day. And I only have patients start to wean in December, January, February. You know why? Because it's cold outside.
Yeah.
Practical.
Yeah.
Yeah. And it's not necessary to wean. You can go off of it abruptly. It doesn't hurt you. But I think a sort of kinder, gentler way is to go off gradually and see how you do gradually so that you don't have a big abrupt change to your system.
I want to make sure I have Gennev's email correct. Is it GENNEV?
That is correct.
Okay, great. Okay.
And we have so many resources. We have articles, blogs, videos. We also have health coaches. They're all registered dietitians. They are terrific at doing non-medical support of the menopause transition, be it with diet, supplements, and other useful techniques that help. So medication is one thing. I do want to put that out there. There are a lot of things we can do to feel better in menopause. HRT is for some women, it's not for others. Some lifestyle modifications can make a huge difference. So it's really a whole package of things.
Can you talk a little bit about those lifestyle changes that women could make that might be, if they're concerned about HRTs, that might be beneficial for them?
Yeah. So a lot of women worry about nutrition and weight. Weight gain is a huge concern at midlife. I always like to describe it as a compensatory mechanism. So as ovaries start to wane and they're not producing the same amount of hormones, where else in the female body do we make estrogen? We make it in fat. Fat converts a couple of other hormones into estrogen. And so we put on some extra and it goes right in the midsection. I call it the midlife midsection. So if you think about weight gain in that context, as your body is trying to help a sister out, trying to make more estrogen, it makes a little bit more sense. And I always like to promote some healthy acceptance of new normal around weight at midlife. Now, none of us wants an onward, upward trajectory of weight gain. It's not healthy for us, and nobody wants that. So I don't mean to discount the weight gain or say just accept it, but some acceptance of a new normal is healthy. I do like the Mediterranean way of eating in terms of nutrition. A lot of vegetables, some lean proteins. I noticed I called it the Mediterranean way of eating and not the D word because I don't like the D word. the Mediterranean way of eating. Of course, there's a healthy eating across many things, named or unnamed. One thing I do want to say is that women come to my office, they complain about the weight gain, and they say, I haven't changed a thing, and this is happening. And I say, well, guess what? You're going to have to change something, because what worked before is not going to work anymore. But we get really indignant around having to change something. I haven't changed a thing. I'm eating the same. I'm exercising the same. And I say, well, we're going to have to change that up. Exercise, always great, and not only for your body, but your mind. And so just the whole spectrum of healthy living, and women know what that is. It's nutrition, it's exercise, it's social connections. It's a whole host of things that we can do. Revel is a great example, social connections, making friends, connecting with other women who have similar experiences. So I wouldn't discount any of that.
Well, and again, sleep and getting
Oh
your
my gosh,
sleep.
yes. Go back to sleep. Everything goes back to good sleep.
It really does, doesn't it? When you don't get a good night's sleep or a couple nights sleep, it affects every aspect of your body. And if you do have brain fog, forget about it. You can't even remember your own name or where your phone is, or.
Yeah, we have to prioritize sleep.
And you become irritable. I become very irritable if I don't get enough sleep. So that is the big thing.
So we want to make sure everyone remembers that we recommended North American Menopause Society. You can go on NAMS.org, NAMS, and they will show you not only doctors in your local area that are certified in NAMS. There are not a lot of them, but there are there. There's also menopause and midlife clinics. There's only maybe 32 or 33 in the country right now, but there are located there. And if you have any questions about that stuff, feel free to email us at hotflashescooltopics@gmail.com. Also, Gennev.com is an online telehealth resource. We work with them and we love them. They just have so much information. And a lot of these websites and communities also have blogs, research articles, the newest information on HRTs, on your health, on your diet. There's information out there, and knowledge is power for everybody. So I really want to thank Dr. Savage for coming on. This was wonderful. We bombarded you with questions and you were very gracious and answered them all. This will be on our YouTube channel, and it will also be an episode. We'll pull the audio from it and we'll make it a bonus episode on hotflashesandcooltopics.com. We'll keep you guys posted on when that will be up in the group on Revel, so that you'll be able to do that. Any last words, Dr. Savage? Anything you can recommend for women who are going through this transition? Like, what's the first step?
I think the first step is to recognize that it can be a problem. Don't let anybody be dismissive or discount the impact that menopause symptoms can have on you. The second part of that is that it can be better. We love to serve women in midlife because so many of them have gone from doctor to doctor and not found what they need. And so I would say be your own best advocate. Keep trying, find someone who will listen and who is open to HRT if you're interested in that. I will say also that our Gennev platform is having a new course. It's called Menopause Foundations, and it's about a 4-series course hosted by a physician like myself or one of our team, open to several participants every session. Education is the key, and that's what everybody here is doing today, getting more information, being their own best advocate. So I congratulate everybody for that.
Thank you, Dr. Savage. And we just want to remind everybody, you can find Hot Flashes Cool Topics on any podcast platform. We are also going to be doing a Mother's Day giveaway. I know it's a little early, but it's maybe 5 weeks from now. Part of the group of gifts that we will be giving is going to be a Gennev Telehealth gift card. We'll also have Hot Girls Pearls for your hot flashes. We'll have supplements. We'll have skincare, you name it. The basket's going to be large, and really, I want it, but Bridget and I can't have it. So there you go. But thank you guys so much for joining us today. If you have any questions, feel free to email us. We're happy to answer them, or at least direct you to someone like Dr. Savage who can answer your questions.
Oh, and someone asked website, but you're on Gennev, is that right?
I'm on Gennev. Yeah, Gennev.com.
Yeah, Gennev.com.
Thanks everybody for joining us. Have a great day.
Thank you, ladies.
Thank you.
Thank you.
Thank you. Bye, guys.
Bye.